So I hope that this will be useful to you. I know that many of you will have lived with this condition for a while, some maybe relatively short time, and so I'm very happy to take any questions either during or after the presentation. And what I'm just going to talk about is what PSC is, how as doctors we may diagnose it, what the symptoms might be, and how we might treat those symptoms. So first of all, what is PSC, primary sclerosing cholangitis? So this is a long-term liver condition, and one of its features is inflammation around the bile ducts in the liver, and I'll talk a little bit more about that in a while. And this inflammation then leads to scarring, first of all around the bile ducts, which leads to narrowing in these tubes that drain bile out of the liver. This usually affects the bile ducts across the liver and outside it as well, in the main bile duct that drains the bile from the liver into the intestine. And eventually that scarring can then spread and form into nodules, and this is what we call cirrhosis when it reaches its most advanced stage of scarring. So first of all, a little bit about what the liver looks like. I'll bring the lights down so that you can perhaps see the slides a bit better. Is that easy to see? Yeah, good. So these are just a couple of cartoons that show, first of all, on this side, what the shape of the liver is and how it relates to the bile ducts, and then as it would be under the microscope. And as a simple medical hepatologist, I was really disappointed to find out that they really weren't green, because they're always green in the diagrams. So what this is showing here on this side is when blood comes into the liver, it then flows across plates of liver cells, and these are the brown ones here, which are called hepatocytes, and these are the factory of the liver where they get rid of toxins and synthesize things that your body needs. So then, when the waste products come out of the hepatocytes, they go into the bile, which then drains down into the main bile duct, and these then join together, as you see here, like small branches joining into bigger branches, and then eventually flowing out of the liver into the intestine, where it helps to digest food and also get rid of the waste products. The blood then, as it passes through the liver, then comes out back up towards the heart, and this is what it looks like normally. So when we think, PSC is a rare condition, as you know, and there's a couple of measures of looking at that. So first of all, we think about how many people might be diagnosed every year, and the prevalence is how many people have that condition already and are living with it in the population. So estimates vary across the world, but in most countries we think that around about 1 or 2 people per 100,000 per year are diagnosed with PSC in the UK, and if the population is 65 million, then that's about 845 per year. How many people already have it? Well, we think around about 16 per 100,000 in the UK, which means that there's approximately 10,000 people who have this condition currently. There's not one test that's used to diagnose it, and there's quite a range of ways that people come to find out that they have PSC. It may be through a simple checkup. You have your blood test checked, and these are found to be abnormal, and further testing is done from there. Sometimes people have symptoms typical of PSC, and that's how they then start getting tested. So we have a combination of the typical symptoms, the typical pattern of blood tests, and usually we can make the diagnosis on a scan, which in most cases would be an MRI scan of the liver, and I have some pictures of that in a moment. In some patients, the MRI might look normal, and we would then go on to do a liver biopsy. We don't need to do a liver biopsy in every case to find out if someone has PSC. This is only needed in special circumstances. And it's important as we find out about the background and we think about the other possible causes of why someone might have abnormal blood tests or an abnormal scan. So you might have heard the term liver function tests, or LFT for short. They don't actually measure your liver function, but they're generally measuring the liver enzymes. The common ones that are included in an LFT are listed here. And the classical thing with PSC is the alkaline phosphatase, which is usually high, although in some people it can be normal. If somebody doesn't have symptoms or they have early disease, the bilirubin, that's the yellow colour that makes you jaundiced, that would usually often be normal too, but sometimes that's how people first find out if they have PSC, if they become jaundiced and then get investigated. In most people, these two liver enzymes here, which usually represent damage to the hepatocytes rather than the bile ducts, often these are normal or a little bit elevated in PSC. If they're very high, then we start thinking about other possible causes. So this is a picture of an MRI scan that shows the bile ducts, and if you think back to the diagram that I showed you, this is showing up white as fluid, and that's how the test is done. It looks at the resonance returning from the fluid signal. So this part here is the gallbladder filled up with bile, and then this is the main bile duct, and I think it's a little bit light in here, so you can't really see on this one because the bile ducts are normally very thin and small, that there are just tiny little branches that are seen throughout the liver in normality. So when somebody has PSC, it might look a little bit like this. And what we're seeing here is you can see that there are bits that are bigger than usual, that's called dilatation, and there are bits where you can't see it at all, so the parts where it's narrowed and the bile's not flowing through it. And you can see that this is spread, this is not just one area, but all parts of the liver are affected by this. And it's a little bit difficult to see the main bile ducts coming out because this can often be affected by the strictures as well. I mentioned earlier about liver biopsy, which we sometimes do if we maybe think somebody's got PSC and they haven't got a typical MRI abnormality. Now, it's quite a patchy condition. If you take a biopsy of the liver, you don't really know what it's going to look like until you look at it under the microscope. And so sometimes you can actually, just by randomly sampling it, you may choose a bit that looks relatively normal. So sometimes, even if somebody's got PSC, the biopsy might not show those changes because they're quite patchy. This one here on the left is what a normal liver would look like, and it's stained pink. So these sort of rounder cells here with a dot in the middle, these are the hepatocytes that I showed you in the first diagram. And then in the middle, there's a collection of a vein. And these structures here are the bile ducts, which are sort of a thin tube with one layer of cells lining it, as you can see by the single purple dots here. And they're usually nice and smooth and regular if they're healthy. And then this is a biopsy taken from somebody who has PSC. And this is the same structure over here as it should be here. And you can see that it all looks a bit disordered. So the bile duct cells themselves don't look very healthy. And then we see this typical pattern of what's called onion skin scarring around the liver, just because it's in layers around this central bile duct. And this is, if we see this, then that's one of the diagnostic features of PSC. We often see a little bit of inflammation. These smaller cells are the lymphocytes or inflammatory cells, and this is another one of the features. So these are the characteristics, and Doug will talk a little bit about the new treatments that target these different areas that are characteristic of the disease. So PSC is probably not just one condition. There's a variety of different features that can, and we find that sometimes we can pick out a group of people who've got different characteristics. So there are some other things that are associated with PSC in the liver. So some of you might have heard of this relatively rare condition now called IgG4-associated cholangitis, which can look like PSC, but the difference is that there are a particular group of inflammatory cells which are causing the problem. They can also cause inflammation in other parts of the body, and this type of condition can respond to steroids. So this is why sometimes we might do a liver biopsy if we think somebody might have this condition, because there may be an extra treatment that we can give that can help. In the same way, sometimes you can have extra inflammation not just affecting the bile ducts, but also affecting the hepatocyte part of the liver, and this is what we call an autoimmune hepatitis overlap. So there's inflammation in the bile ducts, and there's inflammation in the liver. And again, this can respond to steroids as well. Now, sometimes people can have the other common liver conditions as well as PSC, so probably about a quarter of the population have something called fatty liver. And so the two conditions can coexist. And sometimes people can have a reaction to medication such as antibiotics. So we always have to think about if there's a change or if there's a new condition, could it be something else like that? So as I walked in, I can see that your support group poster answers this question, what causes PSC? We don't know, and that's, I say, no known cause, no known cure. There's been quite a lot of research over recent years trying to work out what it is that might cause PSC, and we certainly know that there are genetic factors. We think of this as being an immune condition because it's got strong associations with other immune conditions like inflammatory bowel disease, and skin and eye inflammation. Theories go along the lines of that maybe something in the intestine, changing the group of bacteria that people have, whether that's got a factor in starting off the disease. It may be something within the liver where the bile acids are retained in the liver and may cause some toxicity, and maybe that person's natural mechanism for protecting themselves against that might be affected. But as I say, at the moment, we really don't know, and this is something that people are working hard to try and understand. Who is at risk of getting PSC? Well, the short answer is, of course, anyone can, but often it's people in their young adulthood, and some people can be diagnosed as children. It's unusual for an immune condition where more men than women are affected by this. And as you will know, most people, 4 out of 5 people, also have colitis associated with PSC or inflammatory bowel disease. One of the difficult things in talking to someone who's got PSC is being able to tell them what will happen, because it can be quite an unpredictable disease. These graphs here just show what may happen over time when you think about someone's symptoms and their blood tests, what the colitis might be doing, and what will happen to the progression of scarring in the liver and then the development of symptoms thereafter. So we think about this as something that happens over years, usually not a short time. And many people will have had the condition before they're diagnosed, because obviously if you don't have any symptoms, you wouldn't know that you had it. And this is how sometimes we see people in this time scale when they had a blood test checked and they come to us. And then it's difficult then to say, well, how many years is it going to be before symptoms develop? How long will it be before problems happen? And there's quite a variety in how quickly one person to the next person will progress. In general, over time we see a fluctuation, so something may get worse for a while and then better, and then worse for a while and then better, and then eventually may become progressively worse. The colitis similarly follows a pattern of relapsing and remitting. We think of over time that there is likely to be a progression in fibrosis, and as you know, this is something that our treatments don't change or influence at the moment. And eventually many people will come to develop the most advanced form of cirrhosis or scarring of the liver or cirrhosis, and then other symptoms can arise because of the presence of this scarring. Some people eventually need a liver transplant, of course, which cures these symptoms in the end. So just going to talk a little bit about some of the common symptoms that people get, and then a little bit about what treatments we have to offer them. So someone with early disease can have these symptoms, and someone with later on disease can have these symptoms. It's not related to how bad the scarring is in the liver. So very commonly people will have some generalized itching or pruritus. Tiredness is something that we hear a lot about. An episode of jaundice can occur either through blockage of the main bile duct if you develop a narrowing there, or through infection within the bile ducts, a bacterial infection, and this is what we call about cholangitis. And as the next talk will explore, I think a lot of people don't have to live with the uncertainty of what will happen next year or in 2 years or in 5 years, and I think this can lead to anxiety and concern. When the disease gets more advanced and cirrhosis develops, then these are the symptoms that we watch out for. The scarring in the liver leads to high pressure in the blood vessels that come into the liver, and this is what we call varices when they develop inside the stomach or the esophagus. And these varices may cause no symptoms, or in some people they may bleed. Even without a narrowing in the main bile duct, jaundice can develop in cirrhosis when the liver function gets worse just because of the presence of that scarring. And then these other symptoms are a knock-on effect from that, with retaining fluid, often in the abdomen, poor concentration, loss of appetite, loss of weight. So what would we say to somebody who comes along to the clinic for the first time? We're often asked, what can I do to help myself? Well, I think in general, it's good for people to remain as active as they can and maintain just a normal, healthy diet. There's no special diet with respect to the liver that is necessary to follow. We've no evidence that anything will make a difference one way or the other in people who've got early disease. As the disease goes on and people suffer with weight loss, then we do advise about regular intake of protein and carbohydrate to help maintain that weight. We often get asked about, well, can I drink alcohol? in people who've got any liver disease. Now we know that alcohol doesn't cause PSC, it's got nothing to do with causing it. But if you have one liver disease, then clearly something like alcohol will potentially cause more problems in the long run. And I would usually say to patients who've got cirrhosis to be extremely careful with it. And if you've got cirrhosis with jaundice or other severe symptoms, then clearly not to drink at all. In early disease, I would be very careful with it and not drink on a regular basis. It's important to remember that, as I said earlier, about drug reactions. Anyone's at risk of a drug reaction, and always to think about what other prescription medicines that you might be advised to take. And especially think about over-the-counter medications like herbal remedies, because often these can be quite toxic to the liver too. You'll know that vitamin deficiencies such as vitamin D can be something that people with liver diseases can suffer from without any symptoms, and it's important to check for bone health, for osteoporosis, and maybe take a supplement if your vitamin D is low. If you have also got colitis, then you should have a colonoscopy every year. If you don't have colitis, then we'd normally offer a one-off just to check, because sometimes people have got the condition but don't have any symptoms from it. Then that's important to pick that up. We used to use a medication called ursodeoxycholic acid for everyone, but then some studies have shown that in high doses that wasn't helpful, in fact might be harmful. So we don't use that routinely, but there are certain circumstances where it might be recommended. So a little bit of specifics about some of the symptoms that people can get. So itching, I think, in PSC can be a terrible problem, and it can be. We've got some things that can help, but they'll help some people, and they won't help everyone. So we usually go through the sort of simplest things first of all, and then go on to the things that may work, but have a little bit more in the way of other side effects. So first off is a drug called cholestyramine, which comes in a big sachet. Can be a little bit tasteless or horrible to taste, as I'm sure some of you will know. And this is the first thing that we would offer. If that's not helping, then a drug called rifampicin. I think many people find that to be very effective with itch. And then later on, we've got other drugs that can, in some people, help, particularly naltrexone or sertraline. I'm happy to take any questions about this, so rather than going into the details. And then at the end of the day, if the itch is really very bad, there are some more extreme measures that we can take. But as you can see with all of these measures, there's the first ones are the simplest, the next ones have a little bit more in the way of side effects, and the extreme ones, there's a lot of risk and benefit that we've got to take into account. Tiredness is a very common symptom with PSC, and we try and think about if any other factors are present that we can help with, such as anemia or vitamin D deficiency. Looking for these things and treating them can just help to minimize the symptom of fatigue, and often helping to minimize the itch at night time, which is keeping people awake, can help with keeping energy levels up. I wanted to mention a little bit about what happens with the common complications. So I talked earlier on about jaundice developing through narrowings in the bile duct, and you might have heard this term dominant stricture, which if that occurs, that means there's in the main bile duct that drains the liver, there's one narrowed area, and that then can cause problems with the backup of pressure in the liver and cause jaundice and infection. So if somebody gets symptoms where their liver tests are a bit worse, or they've had an episode of cholangitis, or they become jaundiced, then we'd usually do an MRI scan to look and see if there's been any change in the pattern of strictures, and look for the development of this dominant stricture, because this is something that we can intervene with and treat to help relieve these symptoms. And the way that the intervention is done is to get into the main bile duct that drains the liver using a test called ERCP, which is an endoscopic retrograde cholangiopancreatography. Endoscopic, because we use an endoscope to, this diagram here is sort of goes up a little bit and the mouth is up here. So the endoscope comes down here into the stomach, and then as you leave the stomach and go into the intestine, the bile duct joins just here. You can see that. And then a small wire can be passed up the main bile duct, and that's why it's called retrograde. It's in the opposite direction to the bile flow, to try and identify where there's a narrowing. You can take a sample from it, and you can stretch it or leave a stent in there. There's a small tube that keeps it open, and that then can help allow the bile to drain normally and help relieve the symptoms of jaundice. And so this is a couple of pictures just to give you an example of what that looks like. So this is the endoscope here coming down through the stomach, the little wire going up the bile duct, and then the bile ducts are outlined by an injection of contrast, which then shows you these areas where the narrowings are. And in this one, the main bile duct looks relatively good, and in this one, you can see there are bits where it's a bit narrowed all the way up. Okay. And we often have a little bit of a debate about when we should do this and whether we should do it, because as with anything, there's a potential risk of doing this intervention and a potential benefit. And so we have to think about it very carefully. From the risk side, people with PSC can get infection introduced into the bile duct if you've done this procedure. If I go back a slide, if I can do that. The pancreas gland sits just here, and the pancreas gland produces digestive enzymes. And so if by doing this procedure this bit gets a little bit swollen, then that can cause inflammation in the pancreas, and that causes some pain and can be quite a nasty complication to get. And it happens only in a few % of people who have an ERCP, but still, if you get it, it's quite uncomfortable. And sometimes the wire can pass through the bile duct as well. So these are complications that can occur with anyone, but they are slightly more common in people with PSC. So we'd only do this if we felt there was a significant benefit to be gained. And these are the benefits on this side. Sometimes in these narrowed areas, small stones can form, and these can give ongoing problems with infection and pain. And so we may need to do this procedure to try and relieve that, allow the bile to drain, remove the stones, and reduce the episodes of cholangitis. So it isn't something that's done lightly, but there are in situations where there's a clear benefit. So we see people with a wide variety of symptoms and problems related to PSC, and there are some general things that we do to monitor your health as people come along to the clinic for their regular checkups. So PSC is a rare condition, and we think it's important that people have access to a specialist who knows about PSC and who's got experience in the complications that can happen. So you should have a regular appointment with a specialist like that. And normally when people come, we'd find out about symptoms, do a set of blood tests and look for changes. We offer a test to look at the stiffness of the liver, which can be affected by lots of things. It can be affected by inflammation and cholangitis. But if these things are not present, then it can be affected by scarring. And I think if you had the chance to see the machine at the back there that Davida and Matteo have been using, then this is something that we are doing partly as a research tool, but also to see if it will be useful to help follow the progress of PSC in patients. The guidelines say that an ultrasound should be done every year, and this is what we offer too. So this is to see if there's any changes in the liver, and particularly to look at the gallbladder, because polyps can develop in the gallbladder, and if these occur, then we'd recommend considering removing that. And also, if people come along to us with symptoms, then we'd investigate, as I've explained, for the types of problems that may occur. If somebody's got to the point where they have cirrhosis, then we would look for the other complications that can occur as a result of that. So an endoscopy to look inside the stomach for varices, and we do an ultrasound for every 6 months rather than every year to detect the problems there. So that's the end of my talk. I hope that's been useful. I'm very happy to take any questions now if people would like.